Hi, everybody. Dr. Michael Miyazaki, and we are here again with Dr. Ryan Walsh, an endodontist who's practicing, and he's a great educator. And he's going to be talking to us today about a case because in the past, Dr. Walsh and I have done a lot talking about irrigation, syringes, colored syringes. We've covered everything. But today, what we want to do is kind of step back and talk about clinical situations. And so, Dr. Walsh, it's great to have you, and I'll let you take it away.
Oh, Dr. Mike, thanks for having me again. It's great to be back on the program. And yeah, like you had mentioned, we've talked a lot about the endocator, a lot about irrigation, a lot about kind of the theoretical stuff of how to use this, how it fits into private practice and or clinical practice, I should say, and benefits of doing it and our kind of workflows. But at the end of the day, the proof's in the pudding. How is this translating clinically to actual cases and how is it impacting the way that we're practicing and the way we're treating our patients? And so I wanted to bring a case to share with you tonight. And I hope you enjoy. It's kind of a fun one, especially for tooth nerds like me. And yeah, we'll walk through it together. So um, this lady presented to me for a root canal retreatment on tooth number three. And looking here at the 2D films, you can see that there's four canals filled. I mean, they found the MB2, which on maxillary first molars, that's always the first thing we look for. Am I seeing four white lines? Because if not, then we kind of know what we're looking for. And you can also see that it looks like this the periapical radiolucency has lifted the sinus floor a little bit. You can see a little deviation from that. So you see a fairly pronounced radiolucency at the root tips. And she was symptomatic. She was having pain to biting and pain to pressure, with no surprise. But all things considered, this root canal is not poor quality. It's maybe a little short of the root tip, maybe a couple millimeters short, but maybe that's where the canals exit. So when I look at this, I'm thinking whoever did this was a skilled clinician and a general dentist, I believe, and a skilled clinician that they found the four canals they were looking for. They're dense obturations within a couple millimeters of the root tip. And so what's going on? Why is it going south? Uh, it could be that there was coronal leakage, something like that, absolutely. Or as one of my professors used to say, maybe they missed the canals they found. Maybe they just left
Mhm.
dirty canals inside, and it's radiographic aesthetics. Uh, but I was like, okay, well, regardless of the cause, we need to treat this. So the first visit, I got everything cleaned out. We accessed through the crown. Here's a picture of my access. You can see the red arrows here. That's the MB1 and MB2. But I got everything cleaned out and I placed calcium hydroxide. That's something we do on a fairly common, fairly routine basis. We're not dogmatic in that every retreat gets two visits or every initial is one visit. But in a case like this, she was symptomatic with a large lucency. I placed calcium hydroxide and I let that soak in for a couple weeks and then we see her back to get things finished. And on her second visit, I had done my uh, routine irrigation. At the first visit, I did my routine irrigation. At the second visit, I guess you could call it my irrigation protocol. So at her second visit, I irrigate and we'll add EDTA and let that soak in for a minute. And then I go back with my Chlor Extra for 2 or 3 minutes per canal as a final irrigation, and then we dry. And at that point, that's when I did my indicator reading. And to be honest, I was assuming it's going to be below 10. Routinely, when I get cases back with calcium hydroxide, the numbers are really low, almost single digits most of the time. And so I was expecting it to be really low. But as you can see here, at the second visit, I took my sample and I got an indicator reading of 80. And so, I mean, on a scale of 1 to 100, getting a scale of 80 or getting a score of 80 is something's up. What's going on? I didn't see any canal drainage. I didn't see any purulence. It truly looked like a routine, case. The canals were dry. I was ready to obturate, but when the indicator tells you that that the score is 80, yeah, I'm not ready to obturate. Something else has to be going on. And so at that point, I start kind of troughing with an ultrasonic, just checking for extra canals, extra fins, extra grooves, and sure enough, that's what we found. This simple test gave me real time information telling me that on my second visit, although I'd placed calcium hydroxide, there was still bacteria present. And so at that time, I just troughed and we opened up a quote unquote MB3. It's more or less kind of one fused large MB canal system, but there was unclean canal space in between the MB1 and MB2. And without the indicator, I'd have sealed that right back up, and she'd have probably been back in my office in the next few years for sure, saying that something was hurting with her tooth. And again, you're kind of scratching your head. But in a case like this, where you can take that endoscore reading and translate it directly to clinical practice and say, yeah, there's more than meets the eye here. I mean, to me, the proof's in the pudding, and that's worth its weight in gold because I was able to find that third canal, irrigate everything again, went back through EDTA and Chlor Extra again 2 to 3 minutes per canal, and then we got that endoscore down to 4. So at that point, I knew I was ready to fill from the simple fact that I just watched that endoscore drop. We found the anatomy we were looking for. And so now I can tell her with confidence, hey, I think we have a very good likelihood of success. We're going to continue to monitor this with you, but now I think we're kind of onto something of why that first root canal was ultimately failing long term.
Wow, that's a great case to learn from. So, real quick, I just wanted to go through because some of those that are watching this may not know what some of the things that we're talking about are. So, I just want to go with Chlor Extra
Yeah,
is Vista Apex's sodium hypochlorite. It's 6%, but it has special surfactants in it so that it actually works more effectively than your regular 6% sodium hypochlorite. So, just wanted to clarify that. And then if somebody is maybe catching us for the very first time, the indicator is giving us the endo score. And the indicator is just a chairside device where we withdraw some of the fluid from the canals and we test it. And it's just giving us an indication of the level of ATP. So, anything that's living cells
yeah,
has ATP in it. So we're just trying to figure out, okay, is there bacteria in there? It could be blood. It could be, many different types of cells that cause ATP. But ultimately, we all know that the cleaner we can get the canals, the more likely we are to get healing of that endodontic treatment versus leaving a lot of stuff behind. So, Dr. Walsh, you're absolutely right. We measure from a 0, 1 up to 100. We want to get that score as low as we can. And so when you were first at 80, that just meant, man, it's almost 100% contamination that canal when
yeah.
it's that high. And if you had sealed it up and you were not able to locate that MB3, there'd be a good chance that 6 months later at a recall visit that apical radiolucency would still be there, right? It wouldn't heal up.
Yeah, I mean, I certainly think so. Yeah, like you said, a score of 80 is almost 100% contaminated. So
Yeah.
yeah, I've seen initial cases that don't read at a score of 80.
Yeah, that's
So finding something like that, to me, she was just destined for failure um, had we not dug a little deeper.
So can I ask you, when you found that MB3 and you went down into that, was it still vital or was it, was there purulence or what, do you remember what you found in there?
Yeah, it was just intracanal mud. There
Just
wasn't
mud.
any vitality left. The canals on either side were necrotic. It was just that kind of brownish bacterial milieu that you see inside necrotic cases. And it was just plugged into that little isthmus in between the canals. So
Hmm.
that was just enough space. It doesn't seem like very much, but that's just enough space to harbor a lot of bacteria. And
Hmm.
again, over time, that's just going to not only contaminate your obturation, but then start, showing signs of leakage from the apical tissues. And yeah, again, you'll see that apical lucency at 6 months or a year down the road that's just not healing.
Yeah, and I think this brings up a couple good points because you and I were talking about it before we even started. Is that, again, it's not a judgment of the clinician that originally did the root canal, because you look at that top photo that we're seeing on the screen right now and you see the MB1 and the MB2 and you think, wow, those are just clean, we got
Right.
everything that we need to get. And you could obturate it thinking it should heal up and 6 months or a year later, it's still got that apical radiolucency, and you're saying, okay, what's wrong? Because maybe radiographically it looks okay. I like what you said. You missed the canals that you found, right? So, or you just didn't manage them well. And then by doing a 10-second test, and you and I were talking about this, that the use of the indicator is we use our irrigants, we rinse out with some sterile water, we take a few drops, out of those canals, and we put it in a little test tube, reactant tube, and we shake it around, put in the indicator. In 10 seconds, we see that endo score. So it's not going to take us much longer. It's not even going to cost that much to run this test. But in this case, it saved the patient's tooth. A lot of us would look at that maybe radiographically thinking, wow, it's not healing up. It looks good radiographically. Maybe there's a fracture in that tooth that's just not going to heal up. And we might be thinking we have to extract it. But in this case, because you got that high score, you're able to find that MB3, you're able to get that endo score from 80 down to 4. Basically, you've saved this patient's tooth, and it didn't take much time. It didn't take much cost-wise to do this. And I think that's what we're trying to get clinicians to understand that this isn't a complicated test. You don't have to take a special course. All you do is have to withdraw
Right.
some irrigant, test it, and you're ready to go.
Yeah, I mean, and I'm able to tell my patients now that, hey, I'm going to take a little sample from your tooth and just be sure that it's as clean as we can possibly get it before we seal it. And so, I mean, this particular case, I took two samples, so total that's less than $15.
Hmm.
And then time, other than the actual time of irrigation, it was 20 seconds, give or take, to measure. The first one to measure and see a score of 80, go back to the drawing board and re-irrigate and trough and look for that MB3, and then another 10 seconds to sample the final once I've gone through the irrigation again. And so I think the indicator and the endo score really tell us real-time information. We're no longer sitting on a protocol that, hey, this is supposed to get us clean. Well,
Hmm.
yeah, in many cases it probably does, and especially in a lot of straightforward cases, I bet it's the best way to be consistent with your irrigation. But on the same token, we're seeing these scores. This is assessment-based irrigation. This is telling me real-time information about my patient and their tooth in the chair right now. And so, for 10 seconds worth of a test, I think it's a no-brainer to be using this.
Yeah, no, I think you're absolutely right. And I think there's a couple phrases I think that we'll kind of repeat for the next couple of years as we try to get our colleagues to adopt the use of the indicator. And that is every tooth is unique. Like this example, right? Most teeth are going to have an MB1, large percentage MB2, smaller percentage at MB3. So it's not the clinician's fault necessarily if you find that MB2 and you think you're in clear water. But then, but because every tooth is a little bit different, the indicator gives us an indication of how well we've cleaned everything out. When you get that high score, you keep looking, look for cracks, look for
You bet.
a missed canal like this. And it's not a judgment again on the clinician. It's just because every tooth is unique, we don't always know if we found everything we're supposed to find. And I think the other point that we mention all the time is you can't see clean. Dr. Gilbert, had that great saying that you can't see clean with a radiograph or even with an endodontic microscope looking down the canals as nicely as you've got laid out here. So we many times we rely on our protocol, whether it be the mechanical filing that we do, the irrigation that follows it up. We rely on that protocol to give us the cleanliness in those canals, but we can't really tell unless you do a test like the indicator.
Yeah, absolutely.
Uh,
Uh,
that's it.
it's the first of its kind. We've never been able to do this before. So now to have this chair side, I mean, think about the days when they used to culture these canals. And you just repeat and culture, and that's just the bacteria that you can culture, right? That's not even necessarily the root canal bacteria. But not only is the indicator good for necrotic cases or retreatments, but it also works on vital cases. Because as you mentioned earlier, every living cell, has ATP. So that's the beauty of this device, that it doesn't matter what instruments you use, what files you use. It doesn't matter what irrigation technique you use. It's unbiased. It's just reporting back a number to tell you how clean that patient's tooth is at that exact moment. And that's really the key piece of information that we're searching for right before obturation of a root canal.
Yeah, we know it's something that's very objective. And that's going to be our teaser because Dr. Walsh, we're going to have you present more of these clinical cases coming up. And I know you've got some great tips. You're a great educator when it comes to endodontics, and I look forward to learning more from you in future episodes. So just want to say thank you very much.
Yeah, thanks again, Dr. Mike, for having me back, and I look forward to meeting again.
We're really excited. On April 1st, 2026, Dr. Ryan Walsh is going to be doing a program on the dental learning platform. And the title is Trust But Verify, Redefining Endodontic Irrigation in 10 Seconds. Basically, measure what matters, the future of endodontic irrigation. And I just want to jump down because I was reading the program description. And it's really focusing on the irrigation science, something that, we rely on. It's part of our protocol. And then I think the exciting part is reviewing the newest chairside technology to help verify that we have the canals clean. So we hope that you'll all sign up for that. And I think it really is the wave going through endodontics right now where we can actually follow our protocol, accomplish everything, test it before we do the obturation to be sure we found all the canals, to be sure we've got the canals clean. And then when we obturate, we can all sleep better. So, Dr. Walsh, anything you want to say about the presentation?
Well, I hope you could all join me, and thanks for tuning in. But yeah, you hit the nail on the head. Trust but verify. I mean, that's something that we've been longing to do in endodontics for a long time, and now we have it. We have a chairside test, 10 seconds, gives us the green light to obturate or the yellow light to go back and re-irrigate. So yeah, it's something I'm really excited to present to all of you, and something that I think you'll all be interested in adding into your endodontic arsenal.
Yeah, no, it's great. So it's yeah, Dell Learning and Dr. Ryan Walsh. Sign up. It's going to be a good program. I'll be
Click the
there.
link. We'll see you there.
That's right.